Thank you for joining us this morning. My name is Karen Curtis, and I am a member of the Provider Outreach and Education team here at WPS Government Health Administrators. Aline Sigler is joining me today. She will be monitoring the chat for questions as well as providing some additional information from time to time. In this edition of our Preventive Services series, I'll be discussing ultrasound abdominal aortic aneurysm screening. Now, earlier this morning, my coworker, Jennifer Boniface, held a webinar on the clinical aspects of this service. So if you happen to miss that, it should be posted on our Encore Presentations webpage within the next couple weeks. This next slide is our disclaimer. We do our best to provide the most current, accurate information, but as we all know, Medicare rules can change often. The information that I am presenting is accurate as of today, but the CMS website should be checked often for updates. CMS does prohibit recording of this webinar for profit-making purposes, so we ask that you don't record the presentation. This event is being recorded and will be posted to the WPS GHA website on the Encore presentation webpage, as well as our YouTube channel. This is a new copyright notice, which we must include in presentations that include CPT or HCPCS. And because I am describing how claims should be billed to Medicare, this presentation does have slides that will contain CPT or HCPCS codes. Now that we've gotten all that out of the way, I can tell you what we are going to talk about today. I'm going to start out with a little background information before moving on to coverage and billing. And lastly, I'm going to discuss checking eligibility so that you can avoid any frequency denials. Here's a list of acronyms that are used in today's presentation. If I use any that you are not familiar with, then you can refer to this slide and hopefully that will provide some clarification. I'd like to begin today by talking a little bit about abdominal aortic aneurysms. An abdominal aortic aneurysm is a bulge that occurs in the aorta below the chest in the abdominal area. In the year 2019, it was reported that abdominal aortic aneurysms caused 9,904 deaths. Of those deaths, around 59% occurred in men, and 75% have a history of smoking. Tobacco use can weaken the walls of blood vessels, so the longer that you smoke, the greater the chances are of developing an aortic aneurysm. Studies have also found that this condition occurs more in Caucasians than in any other race. So what are the risk factors? Males over the age of 65 who currently smoke or have a history of smoking are at higher risk. Also, those who have a family history of conditions such as abdominal aortic aneurysms, coronary artery disease. This is usually caused by plaque buildup within the major blood vessels, which causes coronary arteries to narrow and restricts the blood flow to the heart. Hypertension, peripheral artery disease. This disease is caused by fatty deposits or calcium buildup, which narrows the blood vessels and restricts blood flows to the limbs. Lastly would be a previous myocardial infarction, also known as a heart attack. Many times the patient may have no symptoms depending on the location and the size of the aneurysm. If symptoms do occur, they could include back pain, a pulsating or throbbing feeling below the belly, or a dull ache or pain in the belly or side. Although rare, Discoloration or sores could appear on the feet and toes. If an aneurysm were to rupture, the individual could experience a sudden pain in the lower back, abdomen, or legs that is usually severe. The heart rate could increase, blood pressure may drop, and there may be nausea or vomiting, and their skin could be clammy. Next, we'll move on to coverage. CMS defines the term ultrasound screening for abdominal aortic aneurysms as a service furnished to an asymptomatic individual for the early detection of an abdominal aortic aneurysm. Now, I did take this definition directly out of the Medicare Claims Processing Manual, Chapter 18, Section 110.1. It is a procedure using ultrasound waves provided for the early detection of abdominal aortic aneurysms, and it includes a physician's interpretation of the results of the procedure. This service should be furnished to an asymptomatic individual for early detection. Beneficiaries should receive a referral from their attending physician, physician assistant, nurse practitioner, or clinical nurse specialist. The services should be performed by a provider or supplier who is authorized to provide covered ultrasound diagnostic services. The service should not have been provided previously under the Medicare program. And finally, the beneficiary should fall within one of the risk categories listed here. Those include a family history of abdominal aortic aneurysms, a man aged 65 to 75 who has smoked at least 100 cigarettes in their lifetime, or is a beneficiary who manifests other risk factors in a beneficiary category recommended for screening by the United States Preventive Services Task Force regarding abdominal aortic aneurysms as specified by the Secretary of Health and Human Services through the National Coverage Determination process. Now, this last bullet is a lot of words and still kind of vague. So I am going to have Aline add a link to the United States Preventive Services Task Force recommendations. The task force does recommend selective screening of men aged 65 to 75 who have never smoked but may benefit from the services based on the patient's medical history, family history, or other risk factors. This service is covered under Medicare Part B. Co-payments, deductible, and co-insurance do not apply, and the benefit is offered once per lifetime. Now, I did receive a pre-submitted question asking me why this service is only offered once per lifetime, and according to the U.S. Preventive Services Task Force website, abdominal aortic aneurysms associated mortality within 5 to 12 years is rare in men who initially have received a normal ultrasound result. So therefore, they feel that the evidence supports that a one-time screening risk is sufficient. Now we're going to move on and we're going to talk about submitting these claims to Medicare. When billing Medicare, you're going to want to use HCPCS or CPT code 76706. Applicable modifiers are TC and 26 if you are submitting claims on a CMS 1500 or an 837P electronic equivalent. The modifier TC would be used when billing for a technical component while Modifier 26 would be used when billing the professional component. The WPS-GHA website does contain fact sheets on each of these modifiers, and it includes appropriate and inappropriate usage. So I've included those links on the resource slide just in case you want to get more information regarding those two modifiers to make sure that you're using them appropriately. Also, if you bill on the CMS 1500, you're going to want to include the type of service for when billing the screening service. If you submit claims using a UB04 or an 837I electronic equivalent, these are the applicable type of bills. Hospitals can bill using a 12X or a 13X. Skilled nursing facilities should use type of bill 22X for patients who are occupying a Medicare certified bed. Non-certified residents would have their services billed on a 23X. Rural health clinics would use the 71X. Federally qualified health clinics, the 73X, and critical access hospitals would use the 85X type of bill. When services are provided in a rural health clinic or a federally qualified health center, the professional portion of the service is billed on the UB04 or the 837I using the type of bill 71X or 73X and the appropriate 52X revenue code. If the screening is provided by an independent rural health clinic or freestanding FQHC, then the technical component can be billed by the practitioner on a CMS 1500 or 837P under the practitioner's ID. If the screening is provided in a provider-based RHC or FQHC, then the technical component of the service can be billed on a UB04 or an 837I using the provider's ID. For skilled nursing facilities, consolidated billing allows for a separate Part B payment for screening services when the beneficiaries are in a skilled Part A stay. The skilled nursing facility must submit these services using a 22X type of bill. Now, the last topic I'd like to talk to you about today is eligibility. Checking eligibility before providing these services will help avoid frequency rejections. We have a few options for checking patient eligibility. The first is the Interactive Voice Response System, or IVR. You can say eligibility, and after providing some beneficiary information, Preventive Services is one of the information choices that is available. If you have access to the WPS portal, under the Preventative Services tab, you would be able to see if the patient has already received an abdominal aortic aneurysm ultrasound. For providers using the FIS system, you can request access to the Direct Data Entry System, known as DDE, and this will allow you to access the beneficiary's common working file records, which will show a date if the patient has already received the service. The last option is the HIPAA Eligibility Transaction System, known as HETS, and this requires providers to register as a trading partner with our EDI department. Eligibility information is received by submitting a 270 electronic inquiry file, and the system will then provide a 271 response file with information regarding eligibility for screening services. This last slide is the resources in case you'd like to get more information on any of the topics. I did include a link to the Preventive Services tool, which I find helpful regardless of which preventative service you are looking for. I would like to take you out there real quick. Aline, can you confirm that you can see the website?
Yes, ma'am.
Okay, thank you. I do want to mention this because I had mentioned that if you're a Part B provider and you're billing for the abdominal aortic aneurysms, you can include those modifiers TC and 26. Those modifiers are not listed here on this website, but they are listed in the manual. So I just wanted to bring that to your attention because a lot of times this Medicare Preventive Services tool website does give information on modifiers, but since I noticed that they were left out of this, I did want to direct you to the CMS manual, the 100-4, Chapter 18. That would be where you could find information on that. I will go back to the presentation. And then I did include those two links to those two fact sheets that are on our website. Now, before I ask Aline if we've received any questions in the chat, there were a couple pre-submitted questions that I received that I'd like to answer. I was asked if WPS would be creating an LCD for this service. Now, providers can request an LCD to be written. I talked to somebody on our clinical staff, and they said that currently we do not have an LCD, and the reason for that is because the manual gives information on how to bill the services. But since you can request it, I'd like to take you out there. You can submit your request to an email address, which is policycomments@wpsic.com. I will have Aline add that email address to the chat, and our policy department will let you know if this is something that they would consider, or they'll instruct you on how to submit a formal request. You can also check our policy section of the website. We can go out here by going to topics and then policies. We'll just select J5B just so you can see it. Here it does have any articles that we would have out here. Here is the LCD, NCD reconsideration process. Here's the email address that I had Aline put in the chat. So you can contact us, excuse me, and get more information about whether our policy department would write an LCD for that. The other question that I received asked if any additional diagnosis codes would be added to the NCD policy. Now, I did check, excuse me, the Medicare coverage database. I will go out there. There is an article out here that was written by Palmetto that included diagnosis codes, and I'm not sure if that's what the attendee was talking about when they asked about this. Here's the article that I believe they were talking about. There is a notice on here that this is not related to an LCD, but they did list diagnosis codes in this. CMS does have a process for requesting NCDs, and an electronic request can be submitted to ncdrequest@cms.hhs.gov. I will have Aline add that email address to the chat along with the website information. So if this is something that you're interested in having CMS take a look at, then that would be the process that you would go to. Okay, that was all that I had for pre-submitted questions. Aline, has anything come through on the chat?
Is a diagnosis of screening sufficient, or is a second supporting diagnosis required from the secondary risk categories needed?
That is a very good question. I would like to go back to our clinical staff, because as far as the CMS manual and their billing guidelines, they do not give specific diagnosis codes that are required. So I can go back to our clinical staff and I can see if they have any information on that, but I could not find anything as to specific diagnosis codes that need to be included.
Okay, thank you. And we just got another question. This is referring to that Palmetto article. It says, also, you're referencing a Palmetto article. Since we are WPS, this wouldn't apply to us, correct?
It would not apply to WPS. I specifically brought up this Palmetto article because I was asked about an NCD, and because I could not find anything that CMS had listed as an NCD under their Medicare coverage database, this was the only thing out there, so I assumed that's what this person was talking about. This is not a requirement for WPS, no. This was an article that somebody at Palmetto wrote.
Thank you. And as a follow-up, the attendee says, we're seeing denials from Medicare Advantage plans regarding the diagnosis issue. So I'm not sure if you can comment on that, but I just wanted you to know that that also came into the chat.
Okay, Medicare Advantage plans are completely separate. Well, they're separate from Medicare. So usually when a beneficiary chooses to go under a Medicare Advantage plan, then we normally don't see those claims. Those are sent to another plan. So unfortunately, I can't speak as to why they would be denying the service based on diagnosis codes. That may be something that you would need to contact that plan about.
Thank you. And that there are no more questions at this time.
Okay. This brings us to the end of today's presentation. On behalf of myself, Aline, and Provider Outreach and Education, we want to thank you for joining us today. We look forward to your survey comments and hope that you plan to join us for future events.